This conference will now be recorded.
Okay, today we'll discuss about dysmenorrhea and premenstrual syndrome. Coming to dysmenorrhea, it is nothing but it is defined as a painful menstruation. Painful menstruation which is sufficient in a magnitude so that it will incapacitate day-to-day activities. And coming to the types of the dysmenorrhea, it is classified into primary and secondary depending upon the pathology behind it. And clinically, it is divided into spasmodic, congestive, and membranous type of dysmenorrhea. Coming to the primary dysmenorrhea is dysmenorrhea without any identifiable pelvic pathology. And coming to the secondary dysmenorrhea, it is with the presence of some organic pelvic pathology, that is like endometriosis, adenomyosis, or any fibroids or anything else. Coming to the clinical varieties, it is classified into spasmodic, congestive, and membranous. We'll discuss now. So coming to the spasmodic dysmenorrhea, it is a most prevalent type, and this manifests as a cramping type of pain, and generally it will be present in the during first and second day of menstruation. This is the most common type. And next is the congestive dysmenorrhea. This manifests as a increasing pelvic discomfort and pelvic pain a few days before the origin of menses, and thereafter the patient rapidly experiences relief in the symptoms. So it is generally before the onset of menses, and it will decrease with menses. This variety is commonly seen in PID, IUCD insertion wearers, or pelvic endometriosis and fibroids. And the third type is a membranous dysmenorrhea. It is a special group. In this, the endometrium will shed as a cast at the time of menstruation, and after passage of the cast, there will not be any pain, but during the passage, there will be painful uterine cramps. So coming to the primary dysmenorrhea, it is nothing but without any identifiable pelvic pathology. And the instance of this primary dysmenorrhea, it is above 50%, and it is seen mostly in 18 to 25 years of age group. That is almost reproductive age. And the patient profile, the patient will predominantly confine to the adults and girls, and usually appears 6 to 12 months after menarche. So after first menstrual cycle, she'll have mostly this primary dysmenorrhea. And coming to the history of these patients, either mother or her sister will be dysmenorrhea. So this is the etiology. The most common cause of this dysmenorrhea, it is a prostaglandins. See this image. Um, this is mostly seen in ovulatory cycles, and after corpus luteal regression, it will release some progesterone so that the menstrual flow will get initiated. During this time, it will also secrete some prostaglandins and endoperoxystasis and their metabolites. These will increase uterine myometrial contractions, and there will be reduced blood flow, which leads to ischemia. This leads to increased uterine activity and uterine ischemia and sensitization of the terminals to the prostaglandins. All these lead to pain. So this is the main etiology behind the dysmenorrhea. And next common cause is the behavioral and psychosomatic factors. Most of the patients, teenagers, will have a tension and anxiety during adolescence, and this decrease their threshold for pain, and so they'll have dysmenorrhea. And the third cause will be the imbalance in the autonomic nervous control of the uterine muscles. So there will be overactivity of sympathetic nerves. So there will be hypertonicity of circular fibrils and internal loss, which leads to pain. Next is some abnormal anatomical or functional aspect of the myometrium, like uterine dysperistalsis or hyperactivity. In cases like fibroids, in all these conditions, there will be dysperistalsis and hyperactivity, so there will be pain. And role of vasopressin in endotheliums, this is similar to the prostaglandins. So coming to the symptoms and signs, onset pain begins a few hours before or just with the onset of menstruation, and duration will be severity of pain usually lasts for few hours and may extend to 24 hours, but beyond 48 hours, it won't be present. And the type of pain will be spasmodic or colic in nature, and it is confined to the lower abdomen only. And radiation, it is mostly radiating to the back and medial aspects of the thigh, but it never extends below the level of knee. If it extends below the level of knee, there must be some other pathology. Other symptoms will be systemic discomforts like nausea, vomiting, fatigue, diarrhea, headache, and tachycardia will be seen. And rarely, some of the patients may have syncope and collapse when it is associated with severe pain. Coming to the investigations, we have to evaluate her complete blood picture, ESR, to rule out any endometriosis and subacute PID, and other infections like gonorrhea and chlamydia should be ruled out, and pelvic ultrasound should be taken if it is not relieved with medication to rule out pelvic pathology. Coming to the management of primary dysmenorrhea, general measures should be taken, like reassurance for the patient, and improvement of the general health. Anemia should be corrected, nutrition should be provided, regular physical activity should be advised, and then followed by drugs and surgery. If it is not relieved with reassurance and with physical activity, all these, then we'll go with the drugs like prostaglandin synthase inhibitors, like or NSAIDs. These are the mainstay of drugs for dysmenorrhea. The main action of these drugs will be, it will reduce prostaglandin synthesis, which is responsible for dysmenorrhea. So coming to the prostaglandin synthase inhibitors, these reduce prostaglandin synthesis by inhibition of cyclooxygenase enzyme, and this provides direct analgesic effect. And coming to the dosage of this, it is used orally for 1 to 3 days starting with the onset of period, and in some cases continuous therapy during the period, that is in every cycle. It will improve, it will give a better results than administration on a need base. And administration for 4 to 6 months, it is warranted to determine the response to the treatment. The drugs will be indomethacin 25 mg 3 to 4 times daily, or ibuprofen 400 mg 3 times daily, naproxen, ketopronin, mefenamic acid, piroxicam. These are all the drugs. These are all NSAIDs which inhibit the prostaglandin synthesis. Coming to the contraindications, most of the patients who are using these drugs, they'll complain of gastritis, and similar complaints, like gastrointestinal ulcers or bronchospastic hypersensitivity to aspirin will also be seen. In such cases, these drugs are contraindicated. And the next day of drug will be antispasmodics, Buscopan, that is hyoscine compounds, TID, or camlifin, drotaverin. These are given thrice daily. And the next day is oral contraceptives. If even with NSAIDs and analgesics it is not relieved, then we'll go with the oral contraceptive pills. Those who want contraceptive precaution and with the heavy menstrual bleeding and unresponsive or contraindications to antiprostaglandin drugs, these are all indications for oral contraceptive drugs. And coming to the action, as we already discussed, dysmenorrhea we'll see only in ovulatory cycle. So the main action of this oral contraceptive drugs is it will inhibit ovulation. So the patient will have anovulatory cycles which are painless. Coming to the advantages of these OC pills, this will help in regularity of the periods, along with the along with the treatment of dysmenorrhea. It will regularize the cycles, and it will also regularize the flow of the cycle. And desired contraceptive treatment of choice in many young women is also satisfied, and it will also give a relief from the middle smudge pain which is seen during the ovulation. The next is the dihydrogesterone. It is nothing but progesterone. It also inhibits, it does not inhibit ovulation, but it will interfere with the ovarian steroidogenesis. And this should be given from day 5 of the cycle for a duration of 20 days. That is, from day 5 to day 25, we'll administer this drug. And this is continued for 3 to 6 cycles. And other drugs will be codeine drugs. These are rarely used. And coming to the non-pharmacological pain management, this is acupuncture, acupressure, heat therapy, and TENS, that is transcutaneous electric nerve stimulation, abdominal electric or chemical heating pads, or any herbal and dietary therapies, vitamins, minerals, proteins, fatty acids. All these may also improve the patient from this pain. And the next mode is surgery. This is done only for intractable cases, that is, who are not relieved either with general measures or with drugs. Then we'll go for the surgery. The surgical procedures which we'll use will be the laparoscopic uterosacral nerve ablation. That is, the nerve supply, as we already discussed, there will be hypersensitivity of these nerve endings. So we'll just ablate the nerve endings, and then laparoscopic presacral neurectomy or dilatation of the cervical canal can be done, or any injection of anesthetic drugs to the plexus can be given, or laparoscopy can be done to relieve the cause of the pain. This is the management protocol. So when the patient comes to you, first give her assurance, and then we'll go with analgesics or antispasmodic drugs, and then we'll encourage her normal activities. If still it fails, and if we have a contraindications for prostaglandin synthetase inhibitors, or any presence of contraindications of the pill, or patient is wanting a pregnancy, then we'll go with the prostaglandin synthetase inhibitors. And if still it fails, then we'll go with the ultrasound to rule out pelvic pathology and laparoscopy, and then we'll go with the surgical procedures. If there are no contraindications, then we can use both oral contraceptives or prostaglandin synthetase inhibitors. So next will be the secondary dysmenorrhea. Secondary dysmenorrhea, it is nothing but some associate pelvic pathology will be there. That is cyclical menstrual pain in association with underlying pelvic pathology. It is a secondary dysmenorrhea. Often it begins with 1 to 2 weeks before the menstrual flow and persists until a few days after cessation of the bleeding. And pain may be severe. It is premenstrual pelvic congestion will be seen, will be there. So it leads to pain. And there will be increased vascularity in the pelvic organs during the menstrual cycle, so there will be more pain. And the patient profile, usually the age will be 30 years, around 30 years, and she will be a Paris woman. Coming to the etiology of the secondary dysmenorrhea, endometriosis, adenomyosis, subacute endometritis, and copper intrauterine devices, uterine leiomyomatous, that is fibroids, uterine endometrial polyps, any congenital malformations of the uterus where we'll have a dysperistalsis and hyperperistalsis, and intrauterine synechia, that is Asherman syndrome, PID, cervical stenosis, ovarian cyst, pelvic congestion syndrome, and broad ligament varicocele, and Allen-Master syndrome. In all these conditions, we'll have a secondary dysmenorrhea, because there will be in PID, in all such conditions, there will be increased vascularity, which leads to increased pain. And coming to the unilateral dysmenorrhea, some patients may have a unilateral pain that is only on one side. What are the conditions which leads to unilateral dysmenorrhea? Means ovarian dysmenorrhea or bicornuate uterus, unilateral location of the pelvic endometriosis, any small fibroid polyp near one cornea, and right ovarian vein syndrome or colonic or cervical spasm. All this leads to unilateral dysmenorrhea. Coming to the pain symptoms and signs, pain will be dull pain, and there will not be any radiation, and it starts 3 to 5 days prior to the period and relieves with the onset of menses, and depends on the pathology, the onset and duration will be there. Coming to the investigations, we'll go with the CBP and ESR to rule out any pelvic infections, and then pelvic ultrasound to know any presence of fibroids or polyps, endometriosis, adenomyosis. All this can be ruled out in pelvic and ultrasound. And if we are suspecting of any PID or any infection, we have to go with a microbiological cultures from the endocervix or peritoneal fluid in suspected cases. And HSG, if we are suspecting of any underlying Asherman syndrome, that is intrauterine adhesions or synechia. And laparoscopy, it is single and most useful diagnostic procedure, and we can even treat during laparoscopy. And if we are suspecting of any congenital uterine anomalies, then MRI will be the best mode of diagnostic. And coming to the management, first we have to treat the underlying cause, and then we'll go the and symptomatic management. Along with that, symptomatic management should be given, like with NSAIDs or OC pills. And if we have a doubt of pelvic endometriosis, then it may be treated with increasing doses of danazole or OC pills or GnRH antagonists. And IUCD users, if she's having dysmenorrhea, then we have to go for alternative method of contraception. And in congenital uterine anomalies like rudimentary or anything, we have to exercise the rudimentary horn. And next is the diagnostic hysteroscopy, followed by dilatation and curettage should be done, and excision of any polyp or uterine septum, if we identified, then we have to excise those. And dilatation of the cervix, it damages the nerve, so there will be less pain. And next is a diagnostic laparoscopy. This should be followed by lysis of the pelvic adhesions, or if we have any fibroids, then we have to do myomectomy, or if we are having any chocolate cysts like in endometriosis, then we have to drain the chocolate cyst. And then cautery of the laser vaporization of islands of endometriosis should be done. And if we are having any adnexal masses, excision of the adnexal masses should be done. And next is if she's having a spasmodic dysmenorrhea, then we'll go with the LUNA, that is laser assisted uterosacral nerve ablation. We'll ablate the nerve endings of the uterosacral nerve. and then laparotomy for excision of the chocolate cyst or endometriosis, eradication of endometriosis, myomectomy. As we all already discussed, this is a open method, and we can go with the laparoscopy also. So this is the chart. First, if a patient presented with dysmenorrhea, we have to go for with the history, and any associated symptoms should be asked, and history of PID, IUCD, and psychological assessment should be done. And then, with relation to the menstrual cycle, we have to ask her the history. If it is related with the menstrual cycle, then perform detailed examination, and if we have any abnormal findings, then we'll evaluate like a secondary dysmenorrhea, then we'll go for ultrasound, or depending upon the cause, then we'll go with HSG or laparoscopy, and after diagnosis we'll give a treatment, and if symptoms are relieved, then we'll go with a follow-up. If symptoms still persist, then we'll go with the occipils. If on examination, if we have no abnormal findings, then we'll go with the primary dysmenorrhea. If she also needs a contraception, then we'll go with the contraceptive pills, or we'll go with the prostaglandin synthetase inhibitors. So the next will be the membranous dysmenorrhea. This is a rare variety, and the familial instance will be there. In membranous dysmenorrhea, the patient will shed the endometrium as a cast, that is a single layer. She will shed. So the endometrium, instead of being fragmented, strips off in large pieces or even as a whole cast, and this is preceded and accompanied by severe colic pain. And the pathogenesis is not clear, and it does not interfere with conception and pregnancy, and not cured by any childbearing, and it is refractory to all treatment including curettage, and suppression of ovulation by means of occipils administered cyclically for 1 to 2 years is said to be effective in some cases only. And the next will be the PMS. We'll discuss PMS now. uh, so far we have discussed about dysmenorrhea. Now we'll discuss about premenstrual syndrome. This premenstrual syndrome, it is also called as premenstrual tension, and it is a symptom complex which is recognized primarily by the cyclical changes associated with ovulatory cycles. So most of the ovulatory cycles, they in only ovulatory cycles will have a PMS or dysmenorrhea. So this is the main thing, and in anovulatory cycles, the patient will not have any symptoms, either PMS or dysmenorrhea. This premenstrual syndrome, it will occur generally 7 to 14 days prior to menstruation and spontaneously resolves after menses, and it comprises either physical, psychological, or behavioral changes and not associated with any organic lesion. So it is not associated with any organic lesion. It is the main thing. Coming to the etiology, estrogen excess is the main cause, and or progesterone deficiency in the luteal phase. Both these cause to premenstrual syndrome. And the other things will be increased carbohydrate intolerance in the luteal phase or any pyridoxine deficiency, as this vitamin plays a major role in estrogen synthesis and also in dopamine and serotonin production. So pyridoxine deficiency also leads to premenstrual syndrome. And other like increased production of vasopressin, aldosterone, prolactin, and other systemic prostaglandins, all these contribute to the symptoms which are present in the PMS. And fluctuations in the opiate peptide concentration also affects endorphin levels, which will lead to mood changes. The next will be the it is also seen in a woman who underwent hysterectomy, but they who have a preservation of ovaries also suffer with premenstrual syndrome, suggesting that ovarian hormones have a role in premenstrual syndrome. So coming to the clinical features, various symptoms of premenstrual symptoms are seen. Some patients may have a pain, that is headache, breast pain, and abdominal cramps, muscle stiffness, backache, and generalized body ache will be seen. And in some patients, water retention will be seen due to presence of aldosterone, renin, angiotensin hormones. All these will lead to bloating and weight gain premenstrual period. The next will be the behavioral changes. As there will be increased levels of endorphins and serotonin levels will be decreased, there will be low performance and difficulty in concentration. Irritability will be seen, depression, forgetfulness, low judgment, anxiety, loneliness, feel like crying. All these symptoms will be seen in some patients. And dizziness, faintness, vomiting, nausea, hot flushes will be seen. These are all autonomic changes which are seen in the premenstrual syndrome. Coming to the treatment of PMS, for any psychological symptoms, psychotherapy should be given, and counseling and reassurance is very important in all such cases. And we have to provide her nutritional supplements like vitamins, B1, vitamin B1, 25 to 50 mg, and B6 100 mg should be given, and vitamin E 200 mg daily. These all help in a as we already discussed, pyridoxine deficiency will lead to PMS. So supplementation with the vitamins will help the patient with her symptoms. If she's having any breast symptoms, then we'll give a danazole, and GnRH analog should be given. These GnRH analog like leuprorelin acetate, that is 3.75 mg intramuscularly 4 weekly should be given, or triptorelin, buserelin, bromocriptine can also can be given, and this relieves breast tenderness but has side effects like nausea, dizziness, weight gain, and swelling. So it should be used with caution. And if a patient is having any bloatedness, weight gain, or fluid retention and headache, then we have to restrict her fluid intake and salt intake, and then we'll give her a diuretics, and spironolactone 100 mg can be given. The other drugs will be bisphenol 7.5 to 15 mg daily, and evening primrose oil 500 mg TID. This helps in breast pain. It will relieve the breast pain. The other drugs will be prostaglandin inhibitors, mefenamic acid, naproxen. This helps in these improve the mood and physical symptoms. It also helps in relieving the pain. And anxiolytics like alprox, that is alprazolam, 0.25 mg, and antidepressants tricyclics can be given. These improve the autonomic changes, and if she's having any mood changes, these also will get relieved. The other will be the SSRIs, that is fluoxetine 20 mg daily, and sertraline 50 mg can be given. This help in treating physical as well as behavioral symptoms. The other thing will be the progesterone pessaries, that is 200 to 400 mg progesterone pessary can be given daily in premenstrual phase, or Virina ICD can be used. The next drugs will be the OC pills. These, as we already know, OC pills, it will inhibit ovulation and will have an anovulatory cycle, so the patient will have a relief of these symptoms. And estrogen skin patch can also be given instead of pills. That is, these skin patches, it will release 100 mg daily or 50 mg estrogen implant with 100 mg of testosterone. And some general measures like exercise, relaxation, and other hobbies, meditation, yoga are also beneficial. So this is all the management of premenstrual syndrome. Psychosomatic symptoms can be relieved with the supplementation of vitamins like B1, B6, and E, or we can go with the drugs like selective serotonin reuptake inhibitors, or like sertraline and citalopram. And anxiolytics like alprazolam, alprox, alprazolam can also be used. And breast pain, if she's having a breast pain, then we'll go with the danazole, bromocriptine, or GnRH analogs, or we can go with evening primrose oil tablets. And if she's having a pelvic pain and bloatedness, then we'll go with the OC pills, that is Yasmin. And if she's having bloatedness and breast pain, then we'll go with evening primrose oil tablets. And prostaglandin inhibitors, progesterone, Mirena IUCD also helps in relieving this premenstrual syndrome. So this is all about premenstrual syndrome and dysmenorrhea. So far we have discussed dysmenorrhea. What is a dysmenorrhea? What is the types? That is primary, secondary, and clinical varieties: spasmodic, congestive, and membranous. Primary, it is without any pelvic pathology, and secondary, it is with pelvic pathology. In secondary, we'll have as either spasmodic or congestive variety. And we have discussed management. Mostly, we'll give it a prostaglandin synthesis inhibitors, and then if it is not relieved, then we'll go with the OC pills to inhibit ovulation. And if we have any pelvic pathology, then we have to treat the pelvic pathology. Then along with that, we have to go with the NSAIDs or any prostaglandin inhibitors. And surgery will be the last stay. If we have any pelvic pathology, we'll go with the laparoscopic management or laparotomy, and we'll relieve the symptoms. Coming to the PMS, we have discussed what are the causes like estrogen deficiency, estrogen excess or progesterone deficiency, or any serotonin pyridoxine deficiency, endorphins. All this may lead to premenstrual syndrome. And coming to the symptoms, the patient will have pain, physical, psychological symptoms, and autonomic changes will be seen. And treatment, it is mostly with if she is having any pain, we'll go with a mefenamic acid, NSAIDs, or anything. And if she's having bloatedness, then we'll go with or breast pain, we'll go with evening primrose oil, danazole, GnRH analogs, OC pills. So this is all about PMS and dysmenorrhea. Okay, if you are having any doubts, you can ask me, or we'll leave the meeting. Okay, if you are not having any doubts, we'll leave the meeting. Thank you.